Thanks. Thanks. Philip has given a very nice overview of the whole system. So firstly, we have to understand what TXI means. So TXI actually is texture and color enhancement imaging, right? So that's what it stands for. You don't find the X anywhere in that statement, but it's actually texture and color enhancement. So what actually happens with this new technology is that the white light image, which generally is an RGB type input, gets split into two layers, right? So you get a base layer and a detail layer. So the base layer, basically, once the image is split into that, the image itself or the processor itself adjusts the brightness and the tone. So that's what the processor does for that component. And the other component is the detail layer, where the processor again adjusts the texture. So once it split this into these two sub-components, it then starts stacking these images again, and adds on a color enhancement, and gives it as a RGB type output. So in essence, it's basically splitting the image, giving it, if you may, a little bit of additional features, and then rejoining it back as an output. So as a result, what happens, the final picture is that you would get a much better color tone and much better texture definition. So that's what TXI does. So how does it help? It can help with various things. And in the colon, at least, what we have found increasingly is that it helps with increasing detection of polyps. So it can bring that forth. It also helps in a certain extent with characterization. So we have found increasingly that we are able to define polyps better without the need to use any dye or chromoendoscopy. And the final thing which it can do is it can help with the border delineation of flat polyps. So it does give a better texture and hence perhaps better results with resection. So that's what TXI so far has been doing. Obviously, we'll await further studies for that to pan out.
So many modes, so many image enhancing modes, Dr. Raj, and now we have several image enhanced endoscopy modes. So TXI, what I understand is an add-on to what the image enhanced modalities which we are using, like NBI, BLI, and LCI. So white light, it enhances our understanding of the lesion when we are seeing the lesion with a white light. So can we say that this improves the lesion detection, lesion characterization, and demarcation of the borders as compared to the conventional white light?
I think, obviously we'll need more data. We need actually not more, we'll need some data. These are potential applications, definitely. This is just anecdotal experience we're speaking from, but data has to be forthcoming in order to prove this. So we'll have to wait for further studies. There have been, I'm sure, many groups looking at this as well. And the easiest way to pan this out is actually to look at perhaps polyp detection rates with or without TXI and see if there's going to be any gain with the addition of TXI.
Thank you, Dr. Raj, for that overview. And I'll come to Dr. Mohan now. And this RDI has been there for quite some time now. In fact, for almost 5 years, we have been seeing studies coming up with this RDI mode. So what exactly is this RDI mode, which is also called red dichromatic imaging, and how does it help in performing therapeutic endoscopic procedures? Dr. Mohan.
Yeah, and thank you, Zahir, and it's honor to be with Raj and Dr. Philip. Actually, RDI was designed to detect deeper vessels and active bleeding. It is just the reverse of maybe NBI. NBI is designed to give more contrast to superficial vessels, where we use a shorter wavelength color, and that penetrates superficially and that all gets absorbed by the superficial vessels. So superficial vessels become dark, and that is what we see in NBI, especially in superficial cancers, where we can see IPCL better, where we can see early gastric cancer better. But here we want to see deep vessels. Now deep vessel, we need a longer wavelength to go deep. So longer wavelength is red. Now if now why red becomes red is because if you throw white light on red, it absorbs all color and reflect only red. But if you only throw red light on this, so all of the vessel, deeper vessel, will absorb red. So, and also it is very important that if there is actively bleeding ulcer, now this is a additional from X1 platform, where if you put red on red, that everything becomes reflected, while if you put amber color, that gets absorbed. So using amber color, one is that you can stop that for a while there. Yeah. So if you put amber color there, it gets absorbed. Yeah. Now just back one. If you can stop there. Yeah. This is very important to understand. So if you are using a shorter wavelength, it is not reaching to the depth. One. Yeah. Okay. One more. Okay, now stop here. Okay. Now, if you see, if you're using shorter wavelength light like green or blue, it is not reaching to the deep vessel. So they are not good for deep vessels. While if red is reaching, but since hemoglobin reflect everything there, there is no contrast. But if you use amber color light, the amber color light is a long wavelength. It reaches deep. That means it can catch this deep vessel, but it get absorbed. So it becomes slightly darker or different color. So it is more visible. So if you use amber color light, that is RDI, you can make the deeper vessels more visible. And that is the protocol which they use. So that is the addition of one amber light. And second thing, a property of amber light is that when the concentration of blood is excessive at one place, it get absorbed more as compared to where the concentration is less. So suppose you are doing a ESD, when there is a pool of blood, there is an actively bleeding oozing point where the amber light absorbed, while in periphery it doesn't get absorbed. So there will be a differential enhancement or coloring of a bleeding side, where you can pinpoint the bleeder much better. So this is the principle of RDI. It is to make the deeper vessel more prominent, and two, in a pool of blood, you can identify a bleeder much better. And it is supposed to reduce stress on endoscopic mind.
So what we can assume, Dr. Mohan, because this RDI mode is having both green and amber. Green is supposed to detect the superficial vessels, and red, amber are supposed to detect the deeper vessels. So you have this feel of both. You can see both superficial vessels as well as the deeper vessels, which can be there, whether it's a tumorous lesion or whether you are planning for a resection procedure. You can try and avoid these deeper vessels.
So sometimes what happens in POEM or in ESD, if you hit the blood vessel, it can cause bleeding and your dissection planes are lost. So you want initial incision to be very clean, and RDI may help in that. In fact, we published a paper on video GIE showing that if RDI, you can see on the right side, these are the deeper vessels. So you can place your incision on relatively avascular zone by avoiding deep vessels, which are more visible, much better visible on RDI as compared to the white light. And this is the second use. Second use is, if you use white light, everything becomes red. And if you use RDI, you are able to pinpoint one bleeding point. So these are the two basic uses of RDI. There are other uses also, which are, I think, will enumerate, but these are the two. One is to identify the deep vessel to place your incision. Two, in a bleeding scenario, you can identify the vessel.
So with that, I'll come to Professor Philip. Professor Philip, besides this, there are several studies which suggest that probably the use of RDI can be more than just to identify the bleeding site, and it can have more potential uses. Can you just enumerate some of the more practical uses of this RDI platform?
Yeah, I think at this moment, of course, the application of the bleeding site is excellent to identify the bleeding area, and especially when there is a blood, blood active bleeding. But I think in the future, I mean, some of the investigation or research might be focusing on the management of GI bleeding, or especially also on the identification of variceal bleeding point, and where we may be able to see, as mentioned earlier, that we may be able to see deeper vasculature. So that may allow us to have a better identification of the variceal point, and also to target at the correct site for endoscopic therapy for the varices. So I think these are also an important application in the future.
Right. So great. So there can be many potential uses. Unfortunately, still we don't have enough data to support other uses of RDI. Some of the studies that have been published with regards to the identification of ideal injecting point for sclerotherapy during this varicose treatment. And some of the studies, they say that it allows you to maintain a clear visibility during a colorectal ESD, where sometimes you have this fatty tissue which obscures your plane. So these are all potential uses. There are no large quality data available for that, but these can be some of the potential uses that can allow us to incorporate RDI into our routine practice. So another question is, there are several RDI modes, and the beginners often find it confusing that which RDI mode to use when. Although the data is very limited and it's still in experimental phase, I believe, but there are several RDI modes, RDI 1, 2, and 3. So for beginners, Professor Philip, what do you think? What are the RDI modes that you will prefer for bleeding or for other uses?
I generally use RDI 1. I mean, just the very normal type of RDI. And I think for diagnostic purpose, or even for recognition of any pathology, then RDI 2, RDI 3 may be better. But I think for bleeding, RDI 1 is probably the office mode that we will use, because you just want to identify the bleeding point and then stop the bleeding.
Yeah. In fact, RDI 1 has been used most extensively. Even we have used RDI 1 most often. And I'll ask the same question to Dr. Mohan. Dr. Mohan, do you have any experience with RDI 2 and RDI 3?
Yeah. So we spoke to the company, and they specifically given us, and we also use that to identify. So once you are doing the incision, come to the RDI 2, so that you can identify the deeper vessels better, and then you can make an incision. But once you have gone into the submucosal plane, always switch on to RDI 1, where the only function of that mode is to stop bleeding or to delineate the bleeding vessel. So as Philip said, majority of the studies on to identify the bleeder, and that can be very well done in RDI 1 mode, while 2 is to identify the deeper vessel for incision. We have not used RDI 3 mode, especially they have recommended for identification of inflammation better, especially in ulcerative colitis, which allows us to see through some residue, but I am not sure about that.
Yeah, Dr. Raj, you want to make a comment?
Yeah. The one tip which we have learned from using the RDI 1 mode is that if you see a pool of blood, it generally appears to be yellow, and the active point is actually orange.
Yeah.
So orange
Exactly.
within a pool of yellow. So it may enable one to sort of, I guess, focus or target the hemostatic device to the area which is orange. That's what
Yeah,
we
that is
found.
the actually very important point. And if you throw white light in the pool, everything looks red,
Yes.
and there is no differential color whether there is active bleeding or accumulated blood. While in
Yes.
RDI, the active bleeder looks orange and the accumulated blood looks yellow. So
Yes.
that makes some difference.
Yes.
So here is one potential use that may be useful in cases where the preparation is not optimal, and there RDI can improve the mucosal visibility. We need more data on that because it is still preliminary, but you can see that these three images which can be compared. The first one is a white light image. You can see a bit of yellowish fluid there, and then you can see the second RDI image and the third NBI image. NBI makes this yellowish pool of fluid look reddish in color, and the principal Dr. Mohan explained before. And you can see that on RDI you can still make out the underlying mucosal texture, at least to some extent. So this may be one of the potential uses. We need to see. We don't have much data to support that. And as Dr. Mohan said that the modes of RDI, some of the modes, they can be used to identify these deeper vessels. And one possible chance is that if you want to know the severity of ulcerative colitis and you want to see the vascular pattern in a more refined way, then this may be of some use. And again, I'll say that we need more study. We don't have enough data. These are upcoming potential uses which may be supported by RDI mode in future. So this is the last aspect that I'm going to discuss, and I'll again ask Dr. Raj. Extended depth of field. This is a very novel feature that is available with this new platform. So what do you want to say regarding this mode, Dr. Raj, and how is it going to help the endoscopist in identification and delineation of lesions?
I think the most useful component to this is, as Philip mentioned, is that you are able to see what's in front of you and what's at the back of the area of focus. So it gives you more or less a more wide field view of what's occurring. But I think especially so is the ability to also then be able to magnify the area of focus. Now, the magnification levels have been quite extraordinary, actually, and the ability to visualize vessels have just, I think it just gives one a totally different view of the ability to then predict histology. So these are the two functions which I can see with this new processor. And I think, again, it will be subjected to further study to see how effective or how different it is compared to the present systems which are available.
So as said, Dr. Raj, one thing I found with this mode, EDOF mode, is that it can reduce the pressure over the beginner, because you need to focus it in a very controlled way. You have to focus the lesion because you know that you need to keep a certain distance and you have to maintain that distance so that you can identify and characterize the lesion very well. Is it possible that with that EDOF mode, you can reduce that dependency on the operator and you can be more free and reliably visualize the lesion, and no need to exactly maintain the distance that is normally required when you are doing an NBI with, say, 190 scope, not using EDOF mode?
Yeah, certainly. I mean, that is, I suppose, one of its applicability and advantages. But again, in all of this, technology is one thing, but technique is still important, and we should not forget that. And of course, with with all of the ability to then focus on an area, we also have to be mindful that one needs to understand what they're looking at. So yeah, imaging forms a very important part of this, or learning how to interpret what's seen once we have imaged something. So we've talked about this, I think, yesterday and today, but it is so important that we understand what we're looking at. But certainly the ability of the individual to move the scope and to focus on something will improve considerably with this EDOF function.
Dr. Raj, I think you have some nice videos regarding this new technology. Would you like to share any video with us? Any colonic polyp video, or
if there's time, I can do that. I'm asking for the permission to share, but
I'll stop my sharing
okay.
and let's see if now you can.
Okay, I'll try. I'll try and see if can you see that?
Yeah.
So yeah, so this is just some of the videos which enables us to see. So that's white light NBI, and this is again TXI. Again, white light of a sessile serrated polyp, NBI on the B slide, and TXI on the right hand side. You can actually see the texture and the color improving considerably compared to a white light image on the A frame. And that is helpful, especially on colonic withdrawal. This is just an example of a lesion which is in the stomach, and I'll just go back. So let's see if this plays. So that's just TXI showing a better delineation compared to white light, which is quite subtle. That's TXI, as you can see there. And this is just on characterization. So the useful thing about this is that we may be able to start using the kudos classification back into play, actually, because chromoendoscopy is actually probably not quite needed with TXI. You can actually see that the pit pattern very clearly seen here in this large polyp, and that's in keeping with kudos type 4. And with a bit of adjustment and underwater technique there, you can actually see the normal pits on one side on the left, and the polyp which is on the right, as you can see there. So sort of quite interesting as well. And this is just the final sort of function with delineation of margins. And again, with TXI, I think this white light and this TXI, you can actually see the margins quite easily. This is quite a nice video of a white light image of a lesion, which looks, it's not very large. It's easy to just take a scan and remove it. But with TXI, you can actually see that there's a lateral extension, those flat areas there, very nicely seen with TXI. So I think this is also important, especially when we want to remove lesions and prevent sort of residual polyp being left behind. It's important to be able to understand where the polyp starts and where it ends. So this was slowly used to mark the lesion before removal. So these are some of the things which can help with this TXI mode.
Raj and Philip, I have one question. With the advent of this LED illumination, will NBI be more brighter and can be used as a detection technique also, rather than only characterization? Do you think in stomach it can happen?
Well, I think, well, that's a very good question. Interestingly, we are very used to the white light. So I I can see much brighter illumination in the stomach, even with the current system, EX1 with the NBI mode because of the LED light. But I'm still preferring on the white light, and then the TXI will be some enhancement of the white light. So now I'm prefer to just primary using the TXI as the initial illumination mode. And if detailed characterization, I change to NBI. So that's probably a more like a habitual behavior nowadays because of the previous investigation with NBI. But that makes my mind believe that it's better for the characterization and illumination better with TXI.
Yeah, I tend to.
Zahir,
Yes.
Zahir, just a quick interruption. We are almost time, so if we can wrap up this session because we need to move on with the other sessions.
Sure.
Nice to see you, Philip, over here. Hope you've enjoyed the meeting so far. Right.
So we to wrap up and to summarize what we just discussed, it has quite some potential new modes, TXI, RDI, EDOF function. So we still need more data, but definitely TXI has something to offer, like delineation of margins, as Dr. Raj showed, beautiful delineation of those margins, and you can mark the lesion, the periphery of the lesion very accurately with TXI. It has definitely something to offer. It's an add-on thing over NBI. This is what I believe. And RDI is, as of now, useful to identify the bleeding site. RDI 1 is the most useful mode as of now. The utility of 2 and 3 are yet to be seen in routine clinical practice. And EDOF, definitely it may reduce your learning curve, but it does not replace your meticulous screening, as Dr. Raj said. And with that, I'm thankful to all the panelists for their nice comments. And Professor Philip, thanks for joining. Dr. Raj, thanks for those nice videos which added to this session a lot. And thanks, Dr. Mohan, for your nice overview over RDI. Thank you for joining. See you.
Thank you,
Thank
sir.
you.
That was very
Thanks,
nice.
Thank you. Thank you.
Thank you.
Thanks, doctor.
Bye.
Bye bye.